Hi, and welcome to our panel today for Redefining Cardiac Rehab, the Virtual CEP, Digital Health and Impact. My name is Crystal Grimshaw. I'm one of our co-chairs for our Continuing Education Committee, and I will be kind of hosting this panel and helping along with our discussion. I'm going to pass it along to Alexis here in a moment to start us off with the introductions. If you have any questions, please use the question feature instead of the chat. Place your questions in there. There is time allotted at the end for a Q&A. With that, Alexis, I will pass it along to you.
Hi, everyone. You can go ahead and next slide there. We just have our agenda here, just our panelist introductions, and then we'll go into discussion topics, and we'll go from there with a Q&A. But my name is Alexis Bhagat. Just a little bit about me. I got my master's in clinical exercise physiology in Illinois. I am ACSM-CEP certified. I did have some internship experience during my master's program, so worked in cardiopulmonary rehab at a local hospital, and then worked in cardiac stress testing and cardiac rehab for my other internship in Northwestern Memorial Hospital. I then got my first job as an exercise physiologist in cardiac stress testing at Northwestern Memorial Hospital, was there for 4.5 years, and then transitioned to Kaiser Permanente, Colorado in 2021, where I did also cardiac stress testing, and now I am transitioned into the virtual cardiac rehab program for our region. And I'm also the co-chair of the Virtual Ventures Oversight Committee.
We can go to the next slide. Perfect. Awesome. Welcome, everybody. My name is Kelsey Paarmann. I am a clinical exercise physiologist. I got my master's from the University of Mary in North Dakota. I currently work as the cardiac rehab program manager for Kento Health. I have about 8 years of experience in cardiac rehab, 3 of which have been within a virtual environment. And I currently serve as the co-chair of the VVOC committee with Alexis.
I think it's my turn. There I am. Hello, everyone. So my name is Barbra Fagan, and I've spent nearly 4 decades in cardiac rehab, starting out as a clinical exercise physiologist, growing into leadership roles across the clinical care, program development, and now virtual innovation. I currently serve as Director of Virtual Growth for Pritikin ICR, after several years of being Chief Change Officer at Channel Health, where I was deeply involved in expanding access to cardiac rehab through virtual care. My roots are deeply based in hospital-based programs. I started at Frederick Community Memorial Hospital, and I did have the privilege of serving as past president of AACVPR. I would like to thank SEPA and Alexis for putting this panel together. I'm really excited to be here, and we've got some great information to share.
I think it's my turn. Hi, everyone. My name is Samantha Schulz. I also am a CEP certified by American College of Sports Medicine. I'm based in Pittsburgh. I have my master's degree from IUP, which is in Pennsylvania as well. I have about 6 or 7 years of experience in virtual cardiac rehab. So I used to work at Move in Health, doing patient care, working one-on-one with patients, and then also moved through some clinical operations, sales, and implementation work. And I currently work at Kento Health in implementation and partnerships. And I've been there since the beginning of 2025. And I am on the VVOC panel or committee with everyone here today.
I'm Danielle James. I also have my master's in clinical exercise physiology from Ball State in Indiana, and I am also ACSM-CEP certified. I have a little crossover experience of internship in undergrad, which is what led me to pursue my master's in exercise physiology. And from there, I did internship/assistantship work at Ball State in cardiopulmonary rehab as well. After that time, I ended up going down to CHM Memorial in Chattanooga. which is how I got involved with SEPA through Matt Thomas. And that's what led me to this committee that I'm a member of. And just last year in June, I joined Kento Health Virtual Cardiac Rehab as well. So I'm also newer to the virtual sector within the last year.
Thank you. I am sharing the slides and I apologize. It seems like there is a delay from when I switch the slides to when they switch on your guys' end. I will try to switch them a little bit earlier, so hopefully that will help. But so leading into our first discussion here, telehealth has rapidly changed how cardiac rehab can be delivered, creating new opportunities for exercise physiologists to support patients remotely. How would you say that the role of the exercise physiologist has evolved as telehealth continues to reshape healthcare delivery, and where do you see our role heading in the future?
So I get to start off with that question. So I got my crystal ball out here. Funny thing that when I went to graduate school, my thesis was on the future direction of cardiac rehabilitation. I did that in 1986. Some of you weren't even born yet. The funny thing is, never did I think virtual cardiac rehab was in the future of what we're doing in this profession. But in 2014, we started talking about home-based cardiac rehab, and it was sort of like, wait, what? And as we continue to evolve, I mean, here we are today, and I see only expansion of the CEP and what we can do. In the next 5 to 10 years, hopefully sooner, I see CEPs leading virtual hybrid cardiac rehab programs. I see CEPs utilizing remote monitoring and trackers and data to individualize more home-based exercise programs and prescriptions. I see us working across the continuum from hospital discharge to long-term prevention. And I see supporting our patients not only with exercise, but with behavior change and lifestyle medicine. Virtual care is really going to allow us to continue to do what we always do, but to expand our reach, and that is going to be a dramatic impact on our patients. So in many ways, what we're doing is the same thing, but now we have the ability to access and reach more. And what we're going to do is we're going to help build confidence, improve our patients' health, and do it at a much larger scale. Who's next?
Sorry, I pressed camera instead of microphone there. Yeah, piggybacking on what Barb said, I do expect that we are going to push our role forward. Virtual is not necessarily replacing the in-center traditional cardiac rehab, but rather expanding our reach to those who maybe otherwise had not had ability to access it. We have a lot of like younger individuals that we're starting to see come into cardiac rehab centers, and that's not always a doable thing for them if they're still working, if they're a mom, if they're a dad, if there's a lot on their plate. So that's kind of what I see adapting in the virtual sectors. We might start seeing a lot more of a younger population more frequently. We might also reach the rural populations who couldn't always drive an hour to our centers. So we'll be recruiting a lot more individuals that way. Our role is also ever changing. As we're in this virtual sector, we have the ability to be able to not only prescribe exercise, but patients can exercise on their own, and it's linked to some technology that we'll get into later. And so it's allowed us to get a better idea of what patients are doing on their own at home. And it gives us more of a longitudinal care management rather than just seeing them session by session in center. So those are going to be some of the neat things that come. Data-driven outcomes, since we can track a lot more data this way throughout various aspects of their day-to-day life rather than just in center. I see a lot of good cardiac research coming from this.
Yeah, I agree with everything you guys said. I think that the role itself is still the same. I think, the shift from in-center to virtual, the CEP role becomes more tech-driven. So we have a lot of wearables, we have a lot of technology we're dealing with now. So I think as a CEP, we have our clinical skills, but now we're also going to be using more technical skills. You're troubleshooting with patients on devices, you're talking about their data with them and using all of that to kind of shift their care. So I think that's the biggest change that comes with the role as a CEP in a virtual setting. And I think that that's just going to keep increasing and keep making CEPs, more well-rounded.
I just want to quick add what Danielle said is we now will have the ability to have data that we don't get in center where what our patients are doing when they're not with us. And the more that we can get that data, that can have an impact on really the future of cardiac rehab and what we truly do outside the 3 times a week that we see them. And technology is really going to help that.
Thank you. Moving into our discussion 2 here, as virtual cardiac rehab grows, many programs are exploring how it can complement rather than replace traditional in-person care. How can hybrid or a virtual cardiac rehab program enhance existing in-person programs rather than replace them? And Kelsey,
Thank you. I think Barb and Danielle kind of covered some of this already, but we talk about those barriers that patients have to attending in-person cardiac rehab. So by adding that hybrid or that virtual component really helps increase access. It provides that flexibility that some of those patients maybe need, especially those younger patients that are working. So being able to get them to actually attend their cardiac rehab sessions or reaching those populations that maybe have to drive an hour plus to get to rehab, it allows them to do their exercise at home with the safety and supervision of an exercise physiologist and really support that program that is delivering the sessions. So it increases that accessibility. We're able to then see greater patient numbers and hopefully program and patient outcomes are improving as well. So in the long run, it's really what's best for our patients and being able to meet them where they are, which might be at home.
Yeah, I agree with that. I think that for me, it's really recognizing the large number of patients that do qualify for cardiac rehab that don't attend. So I think that that gap is something that we see and hear a lot. And a virtual and hybrid program is very helpful in capturing that gap of patients that do qualify and don't come to rehab. So I think that's a really important piece. And then also, we can help any like on-site staff maybe alleviate some stress with patients that can do some virtual care and then get more people in the door, to minimize some wait lists, things like that in the on-site setting.
Yeah, and echoing what my 2 colleagues said, but really this is one of my favorite questions because it is the question that I receive most often. There's a fear that virtual cardiac rehab will replace on-site cardiac rehab. And the answer is no. What we're doing through virtual, it's designed to actually strengthen your on-site program. And, again, patients aren't choosing virtual versus on-site. They're choosing virtual versus nothing. And what we found in the evidence is that when programs offer both on-site and a virtual hybrid, actually both of their volumes grow, both on-site and the virtual. So at the end of the day, this is not replacing care. It's making sure that more patients receive it.
I love how you phrased that. The more patients get to receive it. Gave me some chills. With discussion 3, we've kind of mentioned technology a few times. And how are wearables and digital health tools being used to monitor patients, support safety, and help guide patients in their selection in virtual cardiac rehab? Alexis.
Yeah, so Barb mentioned this earlier, right? Where, wearables outside of cardiac rehab, where we have, the one lead telemetry. Now wearables are being just more enhanced. It doesn't have to be the bells and whistles of like a Fitbit or an Apple Watch. There's even other wearables that are coming out that are much cheaper that patients can purchase. And it's just helping monitor heart rate trends and just their exercise, peak heart rates and all those different things that they're doing at their physical activity level at home that's not monitored in an in-person cardiac rehab facility. It's just great to have those wearables, whether it's, a wearable heart monitor or a watch or a ring. It's just being more expansive. And I feel like the technology has gotten a lot better to detect that. Of course, it's not 100%, but it gives us a very good idea of their trends. And it detects, certain things like if someone's going into AFib or if it's just truly, you know, they're working hard. So it really helps to discern those different variables that we're not able to see from an in-person cardiac rehab standpoint, but they're also able to implement at home if they're comfortable with that. They don't have to wear a 12-lead monitor that we would always put them on, right? They can just wear their watch, get out the door. So it doesn't inhibit them from exercising and making them feel like they're unsafe. They know that they're being tracked in some way or form.
Yeah, expanding on that, you know, while we do not, you know, like she mentioned, we do have a lot of wearables and devices, and while we do not have ECG currently, you know, in a real-time application in the virtual sector, you know, typically ECG is only helpful when we are looking for somebody who already has rhythm issues. Obviously, we don't do anything diagnostic with that in cardiac rehab. So getting those lower risk, moderate risk individuals and getting them onto the virtual side is usually quite simple, and it goes well because we can still see heart rate, blood pressure. They can check blood sugars, oxygen saturations. They can talk with us in real time, you know, so we are good with that risk stratification, and ECG is not been a factor that holds us back when we're talking technology. We do have good check-ins with our patients at the sessions. They have their exercise prescriptions. We have safety protocols. We even have protocols when to stop exercise and when to escalate care up. Whether it's a physician or if we need to call local emergency services, those sort of things are all prepared ahead of time. So that is something that looks a little bit different in the virtual sector. When we talk about technology, right, that also includes our technology to use our phones to call for assistance if the patients need it, not just in delivering exercise to them. And, you know, we do make sure that they have someone home with them if that's something that's necessary for that individual. So there's a little bit of a difference to safety piece in that regard, right? Because we're not there with them. But there is a very clear roadmap that we follow when we are meeting with those patients. So that's just to say, while we may have a different look, it does still hold the same quality standard as a traditional center.
And I just have one thing to add when it comes to some of that telemetry too, is that the virtual setting allows you that opportunity to talk to patients and educate patients about what they're feeling when they're at home exercising. You can really talk about what they're feeling when it comes to AFib and what symptoms are associated and how to adjust that exercise. And it almost forces you to have that conversation more so than you would in center, because if they're in center, there's a different level of comfortability than when they're exercising at home. So being able to help educate what they're looking for, how to manage it at home, is really going to give them that life skill going forward, because they're not always going to be in your program. So that virtual aspect kind of helps build that confidence for the patient at home.
Thank you, Kelsey. With discussion 4, operational implementation and workflow, you know, implementing virtual cardiac rehab often requires organizations to rethink their workflows, their staffing, program logistics. You know, you might have to shuffle some things around. For organizations who are considering moving into this virtual and hybrid cardiac rehab space, what are some of the biggest operational challenges and how are these addressed?
This is a great question, because most of the challenges that programs face with virtual, they're not new. They're the same challenges that we face with on-site. So let's just kind of go through these quickly. Biggest usually is, you know, your physician and medical director support. So it's understandable that there's some hesitation with the docs, like, I don't know about this. The one thing I turn everyone to is, well, two things. The joint scientific paper, so ACC, AACVPR, and AHA, that speaks to the safety and efficacy of virtual cardiac rehab. That's your Bible. That's a great paper and reference. And the other thing is, you'll hear it time and time again. This is not virtual versus on-site. This is virtual versus nothing. And most physicians will embrace that. Reimbursement used to be a barrier. A couple of weeks ago, and the appropriations bill was passed. We have until 2027, to the end of 2027 right now, to demonstrate the use of virtual. So it's on us now to make this happen. AACVPR in their recent webinar basically said it's a mandate. Let's get this done. Let's show that we can do this. Staffing models, programs often worry about, like, how are we going to do this? Do we need more staff? In reality, it's about reallocating your staff. You're doing a lot of the same things. So if you truly are delivering this from your program as a DIY, it's determining who's a champion and who's really going to be providing the oversight for your virtual program. Technology, we've talked a ton about technology integration. We'll talk about it a little bit more in a minute, but really that's kind of like, we already have most of these tools. Then it's figuring out, how do these tools work to optimize what we do? Many programs or hospitals try to retrofit something into the cardiac rehab space, and that's not always the easiest thing to do. And then lastly, program setup. This is where people get stuck. Not because virtual is too complex, because there's multiple ways to do it. So in the end, we're going to talk about like building your own or partnering with a industry partner. So don't let that part get you stuck, because that's kind of the fun. You get to build the plane while you fly it. And I'm just turning it over to my next.
I think it's nice that you talked about reimbursement a little bit there, because that is a big win. I want to add to that that's Medicare, right? So we have the commercial payers that we can start some of these conversations with too, and some commercial payers already support virtual or hybrid cardiac rehab. So if that's the case for your health system, starting that conversation with them can get some of those patients in the door. But if not, that can sometimes be a challenge, in that just making sure you have support from other payers. So being able to start those conversations and making sure that that's something that is available to the other patients as well. In regards to some of that program setup, I think Barb hit it on the head. There's so many ways to deliver it. And that's the fun part, right? You get to build what works best for you and your staff. And sometimes it's just reaching out to other peers in your health system or other health systems that have done this before, to see what's worked and what hasn't worked. Attending webinars like this to get feedback too is great. So use your resources, because that's really going to help with some of these operational workflows and implementation challenges you may come across.
Yeah, I think you guys touched on everything. I really just think, like the buy-in is really important for implementing a virtual program. So along with the physicians, just the staff, like getting everyone on the same page, the education of how it's valuing the program and not taking away from anything that anyone's doing is really important too.
Thank you. With discussion 5, delivering education and the whole person care virtually, as we all know, cardiac rehab extends beyond just exercise and includes education, lifestyle support, and addressing psychosocial health. How can programs deliver this education, the behavioral support, the mental health screening in the virtual environment?
Yeah, so cardiac rehab in the virtual setting, when it comes to delivering these core components, we are still able to do risk factor management, medication adherence, nutrition, the physical activity guidelines, cardiac symptoms. It's done through a mix of patient questionnaires being sent to them versus filling out a paper one in center. We still do PHQ-9 through a virtual one-on-one video session, similarly to sitting down with them face-to-face at the center when they're doing their intake. We are able to do those sort of things with GAD-7 as well. In terms of the lifestyle counseling, that is an ongoing thing that we can do with patients. Session to session. We can even message back and forth with them in our virtual setting if they have some questions for us. So we do also have ITPs that we are doing with these patients. So we are making sure that we are documenting their goals and their progresses, and we're touching base at their 30, 60, 90 day, similarly like you would in an in-person center. It's just going to be done through the virtual software that your organization is choosing to opt into. So we do have those sort of things that we are able to do with them, and we're able to talk about stress management and lifestyle change, and we can see what they have in home for nutrition, or, as Kelsey mentioned to me the other day, they can grab their medicine bottles and show it to you. So we can have a little bit of an advantage there when they are in their home. We can talk about their real life, lifestyle changes.
And just to piggyback off of that as well, just based on those screening tools like the PHQ-9, the GAD-7, if a patient is flagged for, having pretty high depression or anxiety after their cardiac event, we have the tools and the resources to refer patients maybe, in a healthcare system. They can be referred to behavioral health medicine, or if not, they can be referred to some local counseling or therapy sessions. So the virtual setting, I feel like, is great because we can always check in with patients weekly and make sure that they're doing okay. If there's any changes to that, to their mental states, and or if they have just, they want to talk to someone, I think that's super important. So I feel like that one-on-one connection that they establish with us as a rapport, that can also help, open up to maybe more just help outside of just the walls, or just within this computer here, that they can refer to their doctors, which is really nice. In terms of lifestyle counseling, if a virtual program offers like phase 3, especially if they need help with like smoking cessation, or just with their exercise goals, it really does help with that continuous monitoring and just that accountability of patients, going through this, right? If they're still establishing their exercise or just their lifestyle habits that they're trying to modify, we're there to help them, which is really nice. So I feel like it's almost like personal training one-on-one, but we're able to do that continuously with them.
And just to add on to that, when it comes to education at home with that patient, it's so much more sustainable, I've learned, for the patient, for them to be able to do what you're teaching while you're teaching it in their home. Like it's practical application. They can show you the cooking oils that they're using, and you can walk through the food labels with them. They can show you the bands or the dumbbells that they have, and you can show them how to use them properly. So then when you're no longer with them, they're able to continue to use those tools and those skills that you taught them, because they learned it in their home and in their environment. It's a lot easier for them to retain that information and then continue going forward with it.
Thank you. Excellent points. Barb, if you would like to take us away on building versus partnering.
Sure. This is a question that comes up frequently, and I'm going to ask everyone to reframe it in their head. Think about it. It's not should you build or partner, it's how quickly do you want to leverage this? Because both options are great. One may have a bigger lift than the other. So let's talk about should you decide to do this on your own? So you're going to deliver this from your hospital program, not going to connect with a partner, with an industry partner. You're just going to use everything that you have. Some of the things that you need to consider would be the technology integration. So what are you going to use to host your virtual classes? Would it be Zoom? Is it, Teams? What are you using, and what does your hospital allow you to use? Making sure that two-way audio visual is HIPAA compliant. Some programs try to utilize through Epic. So there, again, we've said it earlier, there are a variety of ways to do these things, but technology integration is going to be key. What are the IT resources? And we all know how IT works within our hospital systems. So will your patients that are in your virtual program be using their own devices, or will you be supplying them devices? And if you supply them devices, like who's going to take care of them? And all of those things really have to be something that we consider when we're building our own virtual program. What will our clinical workflow look like? Where are you going to document? Are you using ScottCare LSI and then you would just document in there? Will you be documenting in Epic? How are you going to bill? What will your patient monitoring be? So all of those things that we've talked a little bit earlier, think about how that would impact your clinical workflow. Will you have a virtual champion? Will everyone be required to participate in your virtual program? Policies and procedures, medical director oversight. We talked a little bit about the safety checks. I think Danielle mentioned that, what's your policy for safety around your patients that are home during virtual? Staff training, adoption. And when I say adoption, I'm saying that as we in this space, we are champions in helping patients change, right? That's what we do. We're change like champions. But when we're asked to change, it becomes challenging because no one wants to be told to change. So how do we change together, and how do we adopt that virtual opportunities for our patients? It's not going away. We have to do this because we can no longer celebrate 30% of our eligible patients receive this life-saving intervention of cardiac rehab. We have to do it. So how do we train staff and help them along that continuum of change? And then again, time to launch. So we mentioned earlier, we have till the end of 2027 to demonstrate to CMS that we're utilizing it and that we're producing good quality outcomes. So when you consider all of the things that you need to consider to build your own, just take into consideration the time to launch. So now let's look at partnering with an industry partner. And we have several of us on the call today. So when you partner with an industry partner, it's either going to be you're utilizing their full service platform, or there's a combination where it's a DIY where they give you the platform, teach you how to use it, and then you kind of do it the way in which you want to do it. So things to consider when you are exploring a partnership is, are they clinical experts in cardiac rehab? And you want to make sure that that partner that you're selecting has a strong background in cardiac rehab, that follow the core components of cardiac rehab, that are following the AACVPR guidelines. It's not just a tech company who's gotten into cardiac rehab. So to me, that is the number one thing that I focus on. Are they experts in the field of cardiac rehab? And is it still cardiac rehab following those core components? Second thing to consider is, where's your referral source? Is the referral source coming from, is the industry partner getting these referrals, or are you the program deciding which candidates that don't want to come or cannot come on site? Are you driving that referral, or is the industry partner driving that referral? Because there's both models out there. Ease of integration. So again, when you select that partner, how easy will that platform integrate with what you're currently doing? Whether it's integrating straight into Epic, whether it's downloading or uploading forms and getting them into your EMR, how easy is that for the program to do? Implementation support, key. When you partner with an industry partner, it's not like you give them the keys to the car and they're like, okay, see ya. It's how much are they with you? Are they going to walk you through training, through onboarding, through best practices? Will there be quarterly meetings where you're looking at engagement and outcomes so that you can keep moving forward? You can take it to the next. Thank you. This is very, very important, is the provider oversight, because there's a variety of industry partners out there, some of which have their own physicians, and some of which the partner will have you utilize your provider. So that's a determination that each program has to make when they're selecting an industry partner. Patient experience, that should be number one for me, but the patient experience needs to be simple. Like if you remember that, I don't know which Staples, maybe the easy button, push that easy button. The partner that you select, you want both that patient experience to be the easy button and the provider experience to be the easy button. Because if it gets complicated, and it doesn't matter, I've seen 84, 90-year-olds in virtual cardiac rehab sessions. And I've also seen 50-year-olds that struggle with technology. So make sure when you're assessing these programs, how easy is it for that patient, and what kind of experience will that patient have? Billing is that's just going to be who's capturing the revenue and how are the services billed. Again, depending on the partner you choose, It could be completely driven by that industry partner where you have nothing to do with that nor the revenue, or it can be a joint collaboration. These are all questions to consider and ask when you're exploring a partner. And then a cost structure. So is it something that it's a shared model? Are there fees? You know, is it a software as a service? Is it based off billable sessions? So a lot to consider. And that's only a few of those items. So again, those are the ones I find to be something that you want to make sure you're looking at. And again, bottom line, not should you buy or build, how quickly can you get this launched so that you can start serving patients?
I want to add something to that list, Barb. I think it's amazing. I think you covered everything really in depth. One more thing I think is worth mentioning is that you as a health system can assess what your needs are and find those gaps. And how does that industry partner help fill those gaps, right? So how can they help reduce burden on your staff or improve your efficiencies or whatever it may be? So finding somebody that helps you in what you need is important in everything that Barb touched on.
Thanks for adding that.
Thank you. Little rapid fire question for you guys. I feel like it goes very well with everything that Barb just talked about with building a program. So now that you've built your program, how do you see that evolving with implementation of the virtual cardiac rehab in companies and hospital systems? Where do you see it going in the next 5 to 10 years? And Sam, if you want to start us off with what you see for our future.
Yeah, sure. Well, I think in the last 5+ years, we've seen a lot of virtual cardiac rehab come about. Companies, they're all, delivering in different ways. And I think in the next 5 to 10 years, we'll hopefully see hybrid cardiac rehab be more of the standard. So, hopefully that's just how cardiac rehab is delivered in the health systems going forward. It won't be virtual won't be its own separate offering. And hopefully it's just a part of the cardiac rehab delivery in the future.
Just to piggyback off of that as well, like what Barb has mentioned and everyone has already reciprocated, it's going to just enhance programs in the future. And it's also going to create a lot of great job opportunities for the CEP role. So I feel like it's just going to be expanding from here.
I think that this implementation of virtual cardiac rehab is really going to allow for technology to grow and expand and really support not only the patient and what they're getting for their program, but clinicians throughout that cardiac rehab journey, so that we're alleviating inefficiencies, we're providing great overall quality of care, and everybody is just is doing great things.
I think we'll see the technology continue to expand. As we all know, AI is a pretty big thing and it's starting to integrate into many components of our lives. So I think we may see AI doing a little bit more work interacting with patients, and interacting with their data and giving them maybe some things to look out for or be mindful of, or it might be able to recognize exercise patterns maybe when they're doing really well or when they're maybe not doing as well, not adhering as well, and maybe it can interact and kind of jump in before they fall off the wagon with exercise and sort of reinforce that good behaviors and good habits. So we might start seeing more of that side of it as well.
Yeah, Danielle, I love that. My Aura Ring knows I'm going to get sick before I actually get sick. So I'm sure that technology in the space of cardiac rehab is absolutely going to explode. What I keep leaning into is the Million Hearts 2027 goal of reaching 70% of those eligible for cardiac rehab. And if you go back to a quote that Randy Thomas said, I think he said it in 2017, and it still resonates today, is that if we take every single bricks and mortar cardiac rehab in the country, fill it to capacity, we would still only reach 45% of those eligible, and we'd have at least a 1-year wait list. Well, virtual cardiac rehab is one way so that in 2027, which is not that far away, you guys, we're supposed to be hitting 70% of those eligible. So this is one avenue to do this. It's one tool in the toolkit. and EPs are going to have a prominent role in making that happen. So I'm excited.
Me and my computer are trying to advance to our closing remarks slide that Alexis will take us away on as soon as it changes for you.
There we go. Yeah, I just want to recap and just have these closing remarks just because I think these are very important keys to remind everyone with the role, the virtual CEP role, and also with virtual cardiac rehab delivery. So the role of the virtual CEP is really expanding. So this is just leading into more innovation with virtual cardiac rehab delivery. And this, telehealth really does enable remote monitoring, coaching, and patient engagement, really reaching those people that we cannot see in person, breaking those barriers. Hybrid cardiac rehab models are the future. Virtual programs complement in-person care. I think we've said that a lot, but we want to just bring that home, that it does not replace it. It really does complement it and enhance it to to the program's abilities. And hybrid models are improving access, flexibility, and program capacity as well. Technology enables safe and scalable care. So with wearables and remote monitoring support, we're able to deliver patient safety outside the clinic and even bring it to home where they are exercising on their own outside of the in-person setting. Digital tools are helping to expand all these continuous care and data-driven decision making. Even if someone is exercising at home, they can even send their AFib data, their EKG strip to the doctors, and they can see that in real time. So we're able to do that now and connect that gap and close that gap quicker than before. Lastly, collaboration drives innovation. And I know Barb touched on this really well, and Kelsey. So partnerships between health systems, clinicians, and technology partners are really essential in this time, and to really expand on that. And also shared insights will continue to advancing virtual cardiac rehab and best practices. And I just want to do a little plug here, looking ahead. So we talked about how if you're building your own program or partnering with someone, but for someone who's a clinical exercise physiologist, whether you're a student or you're already in the field, what resources do you have in this virtual setting? This is a new thing, right? So we wanted to have a plug of this, that we are creating a virtual CEP toolkit. It's coming soon. It's going to include a lot of different resources, education materials, things that we feel, being in the field now, being virtual, in a virtual setting, what can help you and give you the tool set, the resources to now enter into the virtual realm. And so we have like a resource library, which includes a lot of different research articles supporting the benefits of virtual cardiac rehab for the cardiac population, and even establishing an MPI number as a CEP professional. We need to have people know that we are in the field and that we are counted in the US. Education sources, so getting that certifications, getting all the tools, the qualifications that you need to be in the field and to be equipped. So what does that look like? So maybe having prep materials, including study guides, online resources. You may have already that background in your education with your bachelor's or your master's, but in a virtual setting, it might take a little bit more. So that's why we want to create those resources for you and make sure that you are certified as well. And lastly, building that resume and beyond. Again, having your foundation and your qualifications, what does that look like? So we talk about maybe, how to build an online presence, how to build your resume. What should that look like? What kind of qualifications do you need and experience that you should have before entering in the field? And then also an interview prep guide. What does it look like in an interview setting? When COVID hit, I'm assuming all of the interviews went virtual and in the Zoom setting. So what does that look like? Proper etiquette, how to follow up with, someone after an interview, especially in the virtual setting. And there's just much more to that. So we're excited that we are building that for you all. And we're just, excited for more students and professionals to know what it takes to be in that field, just from our experience.
Thank you, Alexis. So we have quite a few questions coming in that have been coming in throughout the discussion so far. If there are any that we don't get to, the panelists have agreed that they'll include the answers to those questions in the follow-up email. So don't worry, we will get to everything. So make sure you look for that email within the week. But our first one here, Given that prediabetes and diabetes are common in our cardiac rehab population setting, do you integrate CGMs and remote patient monitoring in your practice? Have you developed any specialty programs around diabetes or kidney disease or any other chronic illnesses that we see often in our population? I
I
don't
can
know who
start
would
with
like
that.
to take it away first.
I can start with that. That's a great question. I think continuous glucose monitors are the same as blood pressure monitors, pulse oxes, whatever it may be, being able to utilize that data to help with the care of the patient throughout their journey. But cardiac rehab as a basic model for care is amazing. It looks at risk factor management, that lifestyle change that needs to be happening. So you could easily take that kind of care and apply it to other chronic diseases such as diabetes, kidney disease, exercise, oncology, PAD, whatever it may be. And that virtual setting really allows you to pivot. You're not stuck within the walls of a hospital in the things that they are able to offer when it comes to equipment or resources there. You're able to use what they have in their home to really individualize that program for them.
I can just add, we haven't currently had any patients that are using CGMs, but I mean, I used one. It's becoming more and more prevalent. So, basically what Kelsey said, they had patients who have this equipment already, you're just able to access that data readily and use it. So technology just gives you that sort of easy flow into that information.
That is a great segue into this next question, which is about the data that's coming from your treadmills and your bikes or your power meters, or like an Apple Health Watch or Garmin or Polar, whatever device you're going to get that exercise information from. How is that being integrated? Are you connecting to their equipment or to their devices?
Currently, no, we are not connected directly to their devices in their home. That's not to say with the future of technology that we couldn't integrate into those sort of things or equipment could come about. I mean, Peloton has their own programs that you can access from home. So it's not to say that that's not to come. But typically, when we are prescribing exercise, similarly to in center, we are giving them target met ranges and we are putting together thorough exercise prescriptions based on the equipment and accessibility of items they do have at home so that they can reach those METs. And we are talking about the number of minutes and MET minutes a week, and we are educating them on, intensity. So these patients are still hitting those targeted zones like they would be in a traditional center. And we do have ways to input that into like session notes, similarly like you would in center as well, to track those sessions.
Yeah. I mean, we currently have the ability to integrate Fitbit data. And, I know a lot of the programs out there are continuing to add, Fitbit, Apple Watch, Garmin. So as we expand, and, it's also looking at what do our patients have? A lot of our patients have Apple Watches and Fitbits. So the more that we can access what someone already has, makes, back to that easy button, makes it easier for the patient.
And as that technology evolves, not to get too techy here, but most of our stuff connects already. Like our watches connect to our phones. Peloton or our treadmills can connect to apps on our phone. So being able to use those avenues to share data and, connecting our watch to your phone is going to be able to then integrate to your health system and what you guys are using for that coaching. So we're all connected. It's just a matter of getting there when it comes to some of the exercise equipment itself. The watches and all of that, that's already kind of there. We just have to focus more now on what it maybe looks like to get some of that exercise equipment data so that we can better be informed about what they're doing outside of just self-report.
Yeah. I like to go back to the old talk test. We don't need any kind of technology for that to assess, how hard someone's working.
You got to get them singing, Barb.
Yep. I'm not singing though.
with all of this data that we can collect from the wearables or the exercise devices that they're using, how is this integrated into the electronic health record? Anything with compliance and adherence and the HIPAA portion or portion of it, how does all of that integrate into this data that we can get? And as Kelsey said, everything's connected. How does it cross over into that piece of the puzzle?
Mm-hmm. I can just basically start by saying, when you've seen one program, you've seen one program. So every single hospital organization is going to have different, be risk adverse or not, compliance will be involved, legal will be involved, whether you're doing it yourself or you're partnering with someone. So you're going to have to look at all of that. But I can speak from my side of the equation. We check all the boxes because we know that the hospitals need to check all the boxes. So again, when you're partnering and you're looking for an industry partner, what is their IT security? Because that will be asked no matter whether you do it yourself or your partner. IT security. How does it integrate from what we do as an industry partner into your EMR? And there's a variety of ways to do that. If you have Scott Care or LSI, some of those already are integrating right into EMR. So we could do a whole hour webinar just on that particular question. So again, it's going to be very individual for every single organization. There will be contracts.
Lots of them.
If you partner, there will be contracts.
It's also important to note that you don't just want a data dump, right? You want data that's going to add value to your care. So identifying what that data is it a heart rate? Is it calories burned? Is it exercise information or resting information? So evaluating that as a health system and a program to determine what really you need to integrate, because you don't want 50 heart rates from a day. You want maybe the lowest resting heart rate and maybe a peak exercise heart rate so that it can truly add value to your care.
Any other thoughts? All right. This, I think, is one that we haven't touched too much on with the discussion questions and the rapid fire. But what does the intake process look like, whether it's for a full virtual rehab program or a hybrid? Do you strive to have patients attend their intake in person and then switch to virtual as long as there's no barriers? Can you kind of talk about those first steps?
Who wants to go first?
I guess I can go. Oh, sorry.
Go for it, Alexis.
Oh, that's okay. Well, I'm coming from a healthcare system, so our system is a little different. So for us, we used to do a hybrid of either in-person or virtual intakes to start. For our typical screening for that, we also do like a pre-VCR treadmill stress test just so we can assess a patient's exercise capacity, all those different things. So we send out the questionnaires, all those things. So we used to do kind of a hybrid of virtual or in-person, depending if a patient needs help with like technology or they just have, questions, or if we had some concerns of maybe gait mobility, all those different things. But now we've switched to virtual orientations, which I think has been super helpful. A lot of patients, again, with that access to care and just driving to a facility, I think that eliminated that barrier a lot really well. So we've been just doing more of a virtual orientation. We just go over heart symptoms, exercise, what they have access to, what their goals are for the program. And then we analyze their stress test results, and then we talk about the technology portion, at least from our end.
Again, it will matter, if you're doing it on your own within your own cardiac rehab program or you're partnering. So in our situation, if it's a full service virtual, referral comes to us and then we're doing that initial intake. So we've already received the medical records. We do an intake that includes some type of functional assessment, be it a step test or sit to stand, some type of way that we can assess a baseline. And then your typical, goal setting, all of the things that you would do on site would happen in a virtual perspective. We're not seeing, again, if you're doing a DIY and you can do it on your own, you could decide to have that patient come in for an initial visit, a couple visits, and then transition them. Many times when you're partnering, though, it tends to be an either or, because again, remember, I'm going to say this till I'm blue in the face, it's not on-site versus virtual. These patients cannot come for a variety of reasons. So even asking that patient that says flat out, no, I don't want to come sometimes will tend to make us lose that patient altogether. So those type of patients we put straight into the virtual, and then we conduct initial eval, get that functional assessment, goal setting, and then get them in their classes just like we would on site.
And this is a time that you can be creative in what that looks like. So that's the benefit of virtual. They could do an in-person session just to do their assessments, and then they go full virtual, or maybe they do every 30 days they're in person so that you can assess them again or whatever it may be, and then they're in person, virtual, kind of a mix of two throughout the rest of the program. So that initial intake is, again, very similar to what you do on site. It's just how you're going to deliver it for what your program needs. And then the rest of the program can follow suit to what works best.
Yeah, I'm going to do a shout out to Dr. Mike McNamara in Montana, who in 2020 they were delivering a hybrid cardiac rehab program, completely asynchronous. And in Montana, they had a lot of cattle ranchers. And so they would come into the hospital, have their procedure, and then they would go back out like hours away. And so they were able to convince several of their patients to come in for that initial eval. And it was generally 2 sessions. And then these patients would come at a frequency of 30, 60, 90 days, you know what that's in alignment with, to get those ITPs done. So overall, that patient showed up 4 times, but each time had 2 visits, and their outcomes were phenomenal. So if you ever want to get some data to Mike McNamara in Montana and their Department of Health really saw that even coming 4 times over 3 months produced great outcomes. And why? Again, it's virtual versus nothing. So it works. It works, guys.
Thank you. And there are lots more questions. Unfortunately, we are running out of time, so I will make sure that those get to our panelists, and we will have some discussion points in the follow-up email to address those remaining questions. But thank you again, everybody, for joining us today. Just amazing information. We talked about data dump earlier, Kelsey, and I feel like we just had a data dump of virtual cardiac rehab 101. So thank you again. If you guys want to say, we have a few more minutes, any last remarks or, any other information you'd like to share.
I guess I'll just say thank you, everybody, for coming. It seems like a big, scary monster, but it's not. It just takes time. It takes that first step. And once you're rolling, it gets a little easier. So I'm hoping that we were able to help ease some of your concerns here today. But one step at a time. We're all here for the best of our patients. So we got this.
Absolutely. And feel free to reach out to any of us. I mean, the way I look at this, we have a golden opportunity as CEPs to drive the future of virtual cardiac rehab. So jump in, guys. There's lots of people here who can help you.
Thank you again. And thank you, everybody, for joining us today.
Thanks, everyone.
Thank you.
Thank you, everyone.
Bye. Thank you.